2025-2026 ACCESC guidelines as presented by Dr. Asifullah.
It's a complete rewiring of how you look at a 12-lead ECG.
Yeah.
And to truly grasp these new guidelines, you have to look at the historical assumptions we made about clots,
Right. The old standard STEMI versus in-STEMI dichotomy.
Exactly. So a STEMI where that ST segment elevates more than 1 millimeter was just assumed to be a complete red thrombus occlusion, like a totally blocked pipe.
And that assumption triggered immediate catheterization, right? Like within 90 minutes.
Yep. And then the in-STEMI, the non-ST elevation infarction, that was assumed to be just a partial blockage, a white thrombus where, some blood is still trickling through.
So clinicians felt they could just manage it medically and delay the cath lab for, maybe 24 to 48 hours?
Right, 24 to 48 hours.
Yeah.
And the clinical logic seems sound at the time, but the sources reveal a pretty catastrophic 30% failure rate in both directions.
Wow, 30%. That's massive.
It is. Nearly 30% of classic STEMI rushed to the cath lab turn out to be false positives, no actual occlusion at all.
Oh.
And even worse, 25 to 30% of diagnosed NSTEMIS. Those patients who are told to just wait in a bed, they actually harbor a completely occluded acute thrombotic coronary artery.
So they're completely missed just because their ST elevation was like 0.8 millimeters instead of 1.0.
Exactly.
I mean, it makes me think of a bouncer at a club who only lets you in if you are exactly 6 feet tall, just completely ignoring the actual VIPs who might be like 5'11".
That is a perfect analogy. And that structural failure is exactly what's happening in the myocardium. When these total occlusions get misclassified as in-STEMIS, those patients wait an average of 237 minutes for reperfusion.
That's nearly 7.5 hours.
Yeah. And time is tissue. That delay drives a twofold increase in hospital mortality.
2 times the mortality. I mean, that is just tragic, which is why these new guidelines officially shift us into the OMI paradigm, right?
Yes. OMI stands for occlusion myocardial infarction. So the focus is no longer on the height of a wave on a piece of grid paper. It's on the underlying physiological pathology.
Like, is the artery totally occluded, requiring emergent PCI, or is it non-occluded?
No OMI.
Exactly. And capturing that missing 25% of patients requires clinicians to really recognize subtle, highly specific ECG morphologies. You have to understand the cellular physics.
The current of injury.
Right, the current of injury. It starts with what ischemia actually does to a cell's resting membrane potential. Normally, you have abundant ATP in the cell that keeps specific potassium channels closed.
Which maintains that resting electrical potential at around negative 85 millivolts, right?
You got it, negative 85.
But my understanding is that when the tissue starts starving for oxygen, that ATP production just plummets. So those potassium channels suddenly fly open, potassium leaks out of the cell, and the resting potential rises from negative 85 up to about negative 60.
Precisely. So you now have a pocket of ischemic dying cells sitting at negative 60 millivolts, right directly adjacent to healthy tissue sitting at negative 85.
And 2 different voltages sitting right next to each other generate a current. Exactly. That voltage gradient is the actual current of injury that your ECG is recording.
And the direction of that current dictates what we actually see on the paper.
Yeah, exactly.
Like with subendocardial ischemia, where the damage is just isolated to the inner layer of the heart wall, the current runs toward the ECG electrode on the chest. And that gives you ST segment depression.
Right. But with transmural ischemia, like a full thickness total occlusion, the current runs away from the electrode. That drops the baseline and gives the appearance of ST segment elevation.
Okay, so elevation still matters, but you're saying it's the morphological shape and the proportions that really dictate the injury now.
Absolutely. Take the shrinking QRS phenomenon, for example. As the myocardium becomes electrically inert-like, as the tissue actually dies, it loses its ability to conduct electricity.
See, I always pictured a dying heart generating these massive chaotic spikes on an ECG, but this implies the exact opposite.
Yes, the opposite. The electrical signal is literally fading out, meaning the total height of the heartbeat on the paper actually gets smaller. The QRS complex shrinks.
So if you have ST elevation that is technically less than that magic 1 millimeter, but it exceeds 50% of that tiny shrinking QRS complex,
then that vessel is occluded. The proportion tells the true story, not the absolute height.
That makes so much sense. The sources also highlight some highly specific alarm signals for a proximal LAD occlusion, the classic widowmaker.
The widowmaker.
We hear a lot about hyperacute T waves, but differentiating a lethal hyperacute wave from just a normal tall T wave in, say, a healthy young athlete, that can be super tricky, right?
Incredibly tricky. That's why the new clinical rule focuses on bulk. You're looking at the T wave area compared to the QRS amplitude. If that ratio is greater than 2, that is a massive red flag.
Got it. Ratio greater than 2. What about the terminal QRS distortion?
Yeah, so terminal QRS distortion in leads V2 or V3 is another highly specific LAD signal. You're looking for the absolute absence of a J wave, paired with an S wave that is pulled entirely above the baseline.
Because normally the S wave dips below the baseline, right?
Exactly. And Dr. Smith's landmark 2016 study found that this specific distortion is exceptionally specific for anterior OMI. It is literally never observed in benign early repolarization.
Never. Wow. Which I guess introduces the massive diagnostic minefield every ER doc faces. I mean, the ED is flooded with benign mimics.
Oh, constantly. ECGs that look exactly like heart attacks, but just aren't.
Like pericarditis, right? Inflammation of the heart sac that causes diffuse ST elevation everywhere. How do you tell them apart?
This is where the AVL rule becomes your absolute best friend. Lead AVL sits high up on the left shoulder, looking down at the heart. Because of the anatomy, pericarditis never causes ST segment depression in lead AVL.
Wait, never?
Never. Any ST depression in AVL completely rules out pericarditis, and it's practically 100% specific for an inferior OMI.
It's amazing that just one single lead can cut through that much diagnostic noise, but what happens when the ECG is like inherently distorted, say by a left bundle branch block?
Yeah, and LBBB naturally causes discordant ST changes. It makes it look like there's elevation everywhere. But the 2022 ACC consensus pathway gave a strict STEMI equivalence for LBBBs.
Okay, what are we looking for there?
You hunt for concordant ST elevation of 1 millimeter or more, meaning the ST segment moves in the exact same direction as the QRS, or you look for concordant ST depression in leads V1 to V3.
And if the changes are discordant, like moving in opposite directions,
then you look for excessive discordance.
meaning the discordant ST elevation amplitude is massively disproportionate, right? Like greater than 25% of the preceding S wave depth.
You nailed it. But then, we also have territories this standard 12 lead barely even looks at, like a posterior OMI.
Right, because the standard leads don't view the back of the heart directly.
Exactly. So a posterior occlusion projects as mirror image on the anterior leads. You'll see maximal ST depression in V1 through V4 paired with a prominent upright R wave.
And the sources say that combination carries a 97% specificity for posterior occlusion. And over a third of the time, that depression is less than a millimeter.
See, the millimeter rule just completely fails those patients.
It really does. Now, the guidelines also list these geographic patterns. There's the South African flag pattern, which is subtle elevation in AVL and V2 alongside depression in lead 3.
Right.
And the Aslinger pattern, which is isolated lead 3 elevation with diffuse depression everywhere else. I have to ask, is the expectation really that an overworked resident is memorizing international flags at 3 a.m.?
No, not at all. If you focus on the underlying vectors, you don't need to memorize flags. You just need to understand reciprocal precision.
Reciprocal precision, meaning, well, exactly.
It means if you spot subtle elevation in one area, you immediately hunt for depression in the electrically opposite area. The South African flag just illustrates a diagonal branch occlusion.
Ah, okay. Because the current pulls up towards the left shoulder and pushes away from the inferior leads.
Exactly. You're just looking for the mirror image to confirm the injury is actually real. And the Aslinger pattern just tells you an inferior occlusion is happening, but it's either being visually masked by severe global ischemia.
Like from multi-vessel disease that is pulling everything else down.
Yep. But there is a massive trap here we have to talk about. The AVR trap.
The AVR trap. This is when you have diffuse ST depression across the board, but stark elevation in lead AVR, right?
Yes. And clinicians see that, and they often panic. They assume it's a massive widowmaker clot. But that pattern frequently suggests left main coronary artery disease or a profound secondary supplied-man mismatch.
Supplied-man mismatch. So like severe anemia, extreme hypoxia, or systemic shock.
Exactly. The heart isn't blocked by a sudden localized clot. It's globally starving because the entire body is crashing.
And the stat that blew my mind, 40% of patients with this specific AVR pattern have no severe acute coronary disease at all.
None. Zero. Rushing them to the cath lab could actually kill them.
So the primary directive is to stabilize the underlying shock first, and only activate the cath lab if those ST abnormalities are stubborn and persistent after you stabilize them.
Exactly. Which perfectly transitions us into the resuscitation bay. You've navigated the mimics. You've confirmed a true OMI. The pressure in the room totally shifts from diagnosis to acute stabilization.
Right. And for decades, the absolute reflex for every medical student was MONA, right? Morphine, oxygen, nitroglycerin, aspirin.
Yep, the classic MNA.
But it is incredibly unnerving to realize that treatments considered the gold standard for half a century are actually actively harmful to heart attack patients. Under the new guidelines, MONA is out. The new first 10-minute stabilization protocol is BANOM, B-A-N-O-M.
It's a huge shift. Let's break down the new physiology of BANOM. The B is for beta blockers, specifically oral metoprolol within 24 hours. But the clinical alert here is crucial.
You have to avoid it in cases of shock, bradycardia, or acute heart failure.
Right. Routine 5E beta blockers are no longer recommended at all because they can precipitate cardiogenic shock in fragile patients.
Good to know. Okay, A is for aspirin, which thankfully remains standard. 162 to 325 milligrams chewed immediately to inhibit platelet aggregation.
Simple enough.
Then N is nitroglycerin, 0.4 milligrams sublingually every 5 minutes. But there are strict contraindications here too.
Yeah, you absolutely withhold it if the patient is having a right ventricular MI, or if their systolic blood pressure is under 90, or, and this is a big one, if they've had recent PDT5 inhibitors like Viagra, that could cause a fatal pressure drop.
Okay, now we hit the really crazy reversals. O is oxygen. We used to flood everyone with oxygen, right?
We did, but the strict new rule is you only administer oxygen if their SpO2 falls below 90%.
The mechanism behind this completely blew my mind. When a patient is having a heart attack, their myocardium is dying from a lack of oxygenated blood. It seems so counterintuitive that giving them extra oxygen would be bad.
I know it sounds backwards, but it comes down to reactive oxygen species and the endothelial response. Routine hyperoxia, like flooding a normoxic patient with extra oxygen, actually triggers powerful coronary vasoconstriction.
Wait, really? So you are chemically clamping down the exact vessels that are already struggling to supply the heart?
Yes, you are literally accelerating the ischemia.
That is wild. And then there's M, morphine, which was the absolute default for severe chest pain.
Not anymore. Now, morphine is strictly reserved for cautious food use, and only for persistent, intractable pain.
Because of the pharmacology, right? Morphine significantly delays gastric emptying.
Exactly, which severely delays the gastrointestinal absorption of the oral P2Y12 inhibitors you're giving them.
So by giving them morphine just to make the pain go away, you are essentially trapping the crucial antiplatelet drugs in their stomach. You're stopping them from reaching the bloodstream to break up the clot.
You are directly sabotaging definitive reperfusion, and that is exactly why Banam has officially replaced MANA.
Wow. Okay, so once Banam is executed and the patient is stabilized, the clinical focus shifts to definitive reperfusion and adjuvant therapy. And the guidelines organize this pharmacological artillery under a new acronym, thrombins.
Right, thrombins. Let's run through it. T stands for the P2Y12 inhibitors like ticagrelor or clopidogrel. But the guidelines lay down a massive pearl here. You never pretreat with prasugrel before the coronary anatomy is known via angiography.
Why is that?
Because if the angiogram reveals complex multivessel disease that requires emergent bypass surgery instead of just a simple stent, prasugrel dramatically increases the risk of catastrophic surgical bleeding. You just have to wait to see the anatomy.
Makes sense. H is for heparin. Unfractionated heparin is mandatory if they are heading to PCI.
Yep.
R is for RAS blockade. ACE inhibitors or ARBs initiated within 24 hours. But the guidelines specifically target this for anterior MIs or patients with an ejection fraction under 40%. Why focus RAS and blockade so heavily on anterior infarctions?
Well, anterior masses cause massive damage to the front wall of the left ventricle. As that tissue dies, the heart attempts to compensate by undergoing severe structural remodeling. It stretches, it thins out, it dilates.
Which rapidly leads to heart failure.
Exactly. And ACE inhibitors basically chemically halt that structural warping.
Okay. Then O, M, B, and N just carry over directly from the Banam stabilization we just talked about. Oxygen, morphine, beta blockers, nitrates, all with the strict restrictions we covered.
Right, which leaves the S statins. The directive here is high-intensity statins, like atorvastatin, 40 to 80 milligrams, given as early as possible. You're targeting a greater than 50% reduction in LDL cholesterol.
And it's not just about lowering cholesterol for the long term, right? Don't statins provide immediate pleiotropic effects?
They do. They stabilize the inflamed endothelium and help prevent other plaques from rupturing right then and there.
Got it. And finally, the I in thrombins stands for invasive strategy, the cath lab. And the timelines here are super rigid because they are tied directly to the wavefront phenomenon of myocardial necrosis.
Right. When an artery occludes, the tissue doesn't just die instantly. The death spreads like a wave from the inner subendocardium outward to the epicardium.
So it's literally a race against that wave. The guidelines say, first medical contact to acquiring an ECG must be under 10 minutes.
Yep. And once an OMI is confirmed, path 1 is primary PCI. The door-to-balloon time must be 90 minutes or less.
Because after 90 minutes, that wave of necrosis has largely completed its path through the wall.
Exactly. The transmural damage becomes irreversible at that point. So the total first medical contact to device limit is capped at 120 minutes.
But practically speaking, what if you are in a rural facility and the nearest PCI-capable center is over 2 hours away?
Then you transition to path 2, which is fibrinolytic therapy, using drugs like TNK or TPA to chemically dissolve the clot.
But the criteria are strict, right? PCI must be more than 120 minutes away, and the patient's symptom onset must be less than 12 hours ago.
Right. Because after 12 hours, the tissue is essentially gone, and the bleeding risk of the clotbuster severely outweighs any benefit.
Makes total sense. And if they qualify, the metric is a door-to-needle time of 30 minutes or less, followed by routine angiography within 2 to 24 hours.
Or an immediate rescue PCI if the fibrinolytic drugs fail to achieve reperfusion.
Okay, so that dictates the flow for a confirmed total occlusion OMI. But what about the patients classified as NOMMI, non-occlusion myocardial infarctions? The artery isn't totally blocked yet, but they are high risk.
The guidelines stratify them very clearly. Immediate catheterization, meaning within 2 hours, is exclusively for patients actively crashing. Cardiogenic shock, refractory pain despite medical therapy, or severe hemodynamic instability.
And early cath within 24 hours.
That's for patients without immediate life threats, but who present with high-risk markers. The guidelines cite a GRACE score over 140, positive biomarkers, or dynamic STT changes.
A GRACE score over 140. That factors in age, resting heart rate, blood pressure, creatinine, and cardiac arrest at presentation, right?
Yep. It basically tells you this patient has a massive risk of mortality in the next 6 months. They're incredibly fragile.
Okay, before we leave catheterization timing, there's a morphological distinction we really need to clarify. It frequently trips up students and clinicians. The difference between the De Winter pattern and the Wellens pattern in the anterior leads.
Oh, this is a vital distinction. So the De Winter pattern presents as upsloping ST depression, leading into tall, symmetrical, hyperacute T waves.
And that patient is an anterior STEMI equivalent, correct?
Yes. They are stuck in a highly lethal hyperacute phase of a proximal LAD occlusion that rarely progresses to classic ST elevation. That requires immediate catheterization. The pipe is totally blocked right now.
Okay, but Wellens syndrome, characterized by biphasic or deeply inverted T waves in the anterior, leads or reflects a completely different physiological state.
Completely different. It's a post-ischemic finding. It indicates the vessel was totally occluded, but it has temporarily opened up through natural autolysis. The tissue is currently reperfusing.
The best analogy I've heard for Wellens is comparing it to a massive landslide that blocks a major highway. Wellens indicates the road has been temporarily cleared, but the cliff face above is actively crumbling.
That's brilliant. Yes, it's a critical, unstable stenosis of the LAD. It demands urgent intervention before it buries the road again, but it's not the immediate, drop-everything emergent rush of a De Winter pattern.
The clinical nuance required to spot all this, terminal QRS distortion, proportional T-wave inflation, reciprocal cancellations, De Winter versus Wellens, it's immense.
It takes years for a human eye to truly master. But our sources point to an unprecedented technological leap that's currently integrating into this space. Artificial intelligence.
Yeah, deep learning models are now being trained directly on angiographically confirmed OMI datasets by the actual clinical architects of the OMI paradigm.
It's wild. These AI models can analyze a standard smartphone photo of a 12-lead ECG, detect subtle occlusions, and differentiate them from benign mimics in seconds with 98% confidence.
98%.
I mean, to put that in perspective, human expert consensus often hovers around 75% to 80% on the most subtle occlusions. So an algorithm doing this with 98% accuracy from a smartphone camera, it fundamentally alters triage.
It really does. So just to recap the massive shifts we've unpacked today. Cardiology is officially leaving the rigid, flawed 1mm STEMI cutoff behind. We are embracing the pathology-focused OMI paradigm.
Relying on highly specific morphological rules and reciprocal vectors.
Right. We are stabilizing our patients with the modern Bainum protocol, remembering exactly why oxygen and morphine are no longer these automatic default reflexes, and executing the Thrombins protocol to race against the wave of myocardial necrosis.
The ultimate mandate across all these 2025-2026 guidelines is perfectly clear. Treat the physiological pathology, not the millimeter.
Treat the pathology, not the millimeter. We are finally aligning our diagnostic criteria with the true state of the patient's heart. And that reality leaves us with a final, provocative thought for you to carry into your next shift.
What's that?
Well, if an AI application on a smartphone can now detect complex OMI patterns with 98% confidence spotting the terminal QRS distortion that evades even experienced human eyes, how will this redefine the very nature of medical training?
That is the big question.
In the coming years, will the mark of an expert physician be their ability to flawlessly read the ECG themselves, or will their true clinical expertise lie in knowing exactly when to overrule the algorithm? Think about that next time you hold a 12 lead in your hands. Thanks for joining us on this deep dive.